Hello, I'm Dr. John, and welcome back to Silver Serenity. If you are over 60, those subtle signs, like persistent fatigue or slight swelling, aren't just old age. They could be quiet diabetes symptoms actively destroying your kidneys right now. But don't panic. Recognizing these 7 quiet indicators early provides a crucial window to halt irreversible damage and regain control of your health. Stay with me, because the 7th symptom we reveal is the single most missed kidney warning sign that almost every primary care doctor overlooks. Before we proceed to the material, please share your city, age, and the specific health concerns you are currently facing in the comments below.
The aged body, often a sturdy but faded manuscript, begins to whisper where it once roared. For the older patient grappling with type 2 diabetes, this shift is not just a poetic transition. It is a profound clinical deception. Diabetes, the condition notorious for its verbose catalog of symptoms, thirst, fatigue, tingling, paradoxically begins to quiet down after the 6th decade of life. The classic warning signs that guide younger clinicians often vanish entirely, replaced by vague malaise or functional decline. This silence is the hidden burden, transforming predictable chronic illness into an insidious, often fatal game of hide and seek. The complications are still progressing. Nephropathy and vascular damage continue their relentless march. But the body's alarm system has been deliberately muted, rendering the severity of the illness disproportionate to the patient's perceived complaint. The central problem lies in symptom overlap, a cruel masquerade unique to geriatrics. When a young adult reports extreme fatigue, a physician meticulously searches for hyperglycemia or thyroid dysfunction. When an 80-year-old reports extreme fatigue, the response often defaults to the frustratingly simple diagnosis of being old. In this discussion, we turn our attention to the critical differences between symptomatic and atypical diabetic progression. We, as clinicians, are often guilty of this geriatric reductionism, assuming that any slight decline in mobility or cognitive speed is merely the natural attrition of enthusiasm rather than a signal of massive end organ damage. This complacency is profoundly dangerous because the silence of the symptoms reflects a deep, more systemic failure of the body's sensory apparatus. The most terrifying aspect of this phenomenon involves the nervous system. Chronic hyperglycemia damages the fine nerves responsible for transmitting pain signals, a condition known as severe diabetic neuropathy. This damage extends crucially to the autonomic nervous system, which regulates unconscious body functions, including the cardiovascular system. Cardiac autonomic neuropathy is the reason why silent myocardial ischemia, a heart attack with no chest pain, is exponentially more common in the elderly diabetic population. While a younger patient doubles over with crushing substernal agony, the older patient might experience nothing more than mild breathlessness, sudden, overwhelming weakness, or, chillingly, just feel slightly dizzy before collapsing. The body's primary defense mechanism, the acute pain response, has been effectively severed, turning classic angina into a non-event. This systematic silencing of pain and distress compels a radical shift in diagnostic vigilance. We cannot rely on the usual subjective reports of pain or discomfort. Instead, clinicians must actively hunt for objective signs of failure. A sudden drop in blood pressure, an unexplained fall, or a swift deterioration in gait. Failure to recognize this atypical presentation leads inevitably to delayed intervention, culminating in catastrophic outcomes, including late-stage renal disease, severe stroke, and preventable cardiac death. Understanding this silent pathology is the first step toward managing the complexities detailed in the upcoming chapters, moving from the masked cardiovascular threats to the confounding cognitive and neurological shifts induced by advanced diabetic disease. Failure to recognize this atypical presentation leads inevitably to delayed intervention, culminating in catastrophic outcomes, including late-stage renal disease, severe stroke, and preventable cardiac death. Understanding this silent pathology is the first step toward managing the complexities detailed in the upcoming chapters. Moving from the masked cardiovascular threats to the confounding cognitive and neurological shifts induced by advanced diabetic disease, the most lethal of these masked threats is the silent myocardial infarction. In patients over 60, high blood glucose often damages the small nerves supplying the heart, a condition known as cardiac autonomic neuropathy. This nerve damage effectively turns off the body's internal alarm system. Instead of crushing chest pain, a geriatric patient experiencing a catastrophic heart attack might only report inexplicable fatigue, sudden breathlessness, or unusual This absence of typical pain cues is disastrously misleading. Doctors are trained to look for classic signs, but diabetes fundamentally rewrites the script of acute coronary events. We are not just fighting high sugar, we are fighting the systematic destruction of sensation itself. Peripheral neuropathy, perhaps the most recognizable diabetic complication, advances insidiously in the older body. The hallmark symptom is often described as a mild tingling or numbness in the feet, which progresses over years into complete desensitization. This loss of protective sensation is what leads to undetected ulcers and subsequent amputations. If they can't feel the pebble in their shoe, they certainly won't feel the infection brewing beneath the surface. Furthermore, the autonomic nervous system continues its silent rebellion throughout the body. Orthostatic hypotension, the sudden, dangerous drop in blood pressure upon standing, becomes a major risk factor for falls and subsequent hip fractures. And yet, many patients chalk this dizzy spell up to just getting old. Perhaps assuming that gravity suddenly decided to increase its personal vendetta against them specifically after their 60th birthday. This subtle shift from minor annoyance to life-threatening mobility issue defines advanced geriatric diabetes management. Beyond the vascular and neurological insults, diabetes wages a sustained, quiet war on the brain itself. Cognitive dysfunction is now recognized as a core geriatric diabetic complication. The relationship is bidirectional. Poorly controlled blood sugar accelerates structural brain changes, contributing to vascular dementia, while existing cognitive impairment makes meticulous diabetes self-management virtually impossible. The subtle signs might include difficulty with complex problem-solving, memory deficits, or a slowing of psychomotor speed. Issues often dismissed by family members as normal aging. In this discussion, we turn our attention specifically to these confounding factors. Studies consistently show that older adults with diabetes experience a significantly faster rate of cognitive decline compared to their non-diabetic peers. This deterioration directly impacts their ability to follow dietary guidelines, manage medication schedules, and recognize their own declining health status, creating a feedback loop of worsening pathology. The seventh silent sign often manifests as progressive, asymptomatic kidney failure or diabetic nephropathy. Because the kidneys possess vast functional reserves, significant damage can occur long before routine blood work reveals a serious issue, often presenting clinically only when dialysis becomes imminent. These seven silent signs, silent miss, inexplicable fatigue, cardiac autonomic dysfunction, peripheral, sensory loss, orthostatic hypotension, progressive cognitive slowing, and asymptomatic renal decline are the hidden landscape of geriatric diabetes. They demand a heightened index of suspicion from clinicians and caregivers alike. Ignoring these subtle signals is not just a clinical oversight. It is an active contribution to the premature frailty and mortality of the older adult struggling against the invisible tyranny of advanced metabolic disease. The invisible tyranny we speak of manifests most acutely in the nervous system and the brain, often decades before a diagnosis is formalized. The slow, corrosive effect of hyperglycemia dulls the peripheral nerves, leading not necessarily to the sharp, burning pain patients often associate with neuropathy, but rather to insidious loss of balance, unnoticed foot ulcers, and persistent numbness. Symptoms geriatric patients often chalk up to the inevitable march of time. Simultaneously, cognitive dysfunction creeps in. This is perhaps the most devastating silent sign. Mild to moderate cognitive decline is frequently misattributed to senility, masking the underlying microvascular damage that accelerates neurodegeneration. Failing to recognize subtle memory loss or slowed processing speed as a complication of diabetes is to forfeit the opportunity for intervention when it matters most. In the current discussion, we turn our attention to the cardiovascular system, where silence reigns supreme. Cardiac autonomic neuropathy is a lethal complication where the autonomic nerves controlling heart rate and blood pressure are damaged. This damage eliminates the body's warning system without functional autonomic nerves. An older adult may experience a massive myocardial infarction, a heart attack, without the hallmark crushing chest pain. Instead, they might report vague fatigue, unexplained shortness of breath, or a sudden dramatic drop in blood pressure upon standing. Sometimes they simply complain of being off. The doctor who dismisses these non-specific complaints as anxiety or hypochondria, perhaps muttering about the drama of the elderly, is actively overlooking a deadly silent infarction that the patient cannot physically register. Two further signs contribute to the accelerated frailty seen in this population: persistent, unexplained fatigue and recurrent, non-localized infections. The exhaustion is often rooted in subclinical organ dysfunction, kidney stress, microvascular damage, or silent cardiac issues that the patient is struggling to compensate for. Infections, particularly urinary tract infections, often present lacking fever or urgency, and instead manifesting as acute confusion or sudden frailty. These seemingly minor setbacks are, in reality, milestones in the steady deterioration of the metabolic landscape. They are the systemic warnings that the body's overall resilience is critically depleted, pushing the older adult closer to a state of complex dependency. The totality of these 7 silent signals: subtle neuropathy, cognitive decline, CAN, silent myocardial ischemia, orthostatic hypotension, chronic fatigue, and atypical infections constitutes a profound diagnostic challenge. They do not arrive with blaring sirens, but with muffled whispers that only the keenly attentive clinician or caregiver can decipher. Early detection shifts the focus from managing acute crises to preserving function and dignity, mitigating the rapid progression toward frailty and mortality. The ongoing surveillance for these signs, rather than relying solely on HbA1c control, is the necessary cornerstone of truly comprehensive diabetes care after the age of 60. The surveillance we speak of must pivot away from the simple metrics of youth toward the complex functional reality of advanced age. The complications in the elderly diabetic often do not announce themselves with the theatrical flares seen in younger patients. Instead, they creep in via subtle functional decline. The first silent sign is often cognitive, a mild, persistent slowing of mental processing speed, frequently misinterpreted by both patient and family as just old age. This is not senility, but the insidious footprint of microvascular damage disrupting cerebral white matter integrity. Similarly, peripheral neuropathy, the second sign, rarely presents with burning agony after 60. Instead, we see the subtle loss of protective sensation manifest initially as diminished vibratory perception or a slightly unstable gait, a precursor to falls that ultimately devastate independence. The third and fourth signs concern the heart, often the most lethal of silent saboteurs. Cardiac autonomic neuropathy can assign trait, presenting not as palpitations but as persistent, unexplained fatigue or orthostatic hypotension. The patient feels dizzy when standing up. The autonomic system, designed to regulate the internal environment, becomes progressively dysfunctional. Sign 4 is the chilling reality of silent myocardial ischemia. When the pain pathways are damaged by diabetic neuropathy, a heart attack can occur without chest pain. One might almost admire the sheer efficiency of type 2 diabetes. It so thoroughly dismantles the body's alarm system that the main structure can collapse without a peep, allowing the patient to attribute their impending demise to a bad night's sleep. In this discussion, we must underscore that the absence of chest pain does not equate to the absence of coronary disease. In fact, the lack of pain dramatically increases the threat, transforming what should be an emergency into an undetected tragedy. Sign 5 is the rapid onset of unexplained frailty. This might manifest as sarcopenia, unusual muscle wasting, or unexpected significant weight loss, driven by poor nutrient absorption or systemic inflammation exacerbated by fluctuating glucose levels. Physicians must resist the urge to simply dismiss this weight loss as cachexia related to other comorbidities. Sign 6 often involves the eyes, specifically fluctuating vision that clears unpredictably. While patients focus on the transient blurring, the underlying pathology, often retinopathy and macular edema, progresses silently toward irreversible damage. These sensory shifts subtly erode the patient's capacity for self-care and interaction, leading directly to social isolation and depression, further accelerating functional decline. Finally, Sign 7 focuses on the feet and skin. Seemingly insignificant changes like persistent dryness, subtle discoloration, or small, painless abrasions. These are the telltale indications of severe arterial and microvascular compromise, coupled with sensory loss, establishing the foundation for a non-healing diabetic ulcer. Recognizing these 7 insidious changes requires focused clinical vigilance far beyond the standard physical examination. The objective is not merely to keep the patient alive, but to protect their remaining years from the devastating loss of autonomy associated with unrecognized late-stage complications, ensuring that the final decades are marked by preserved dignity, not relentless decline. Recognizing these 7 insidious changes requires focused clinical vigilance far beyond the standard physical examination. The objective is not merely to keep the patient alive, but to protect their remaining years from the devastating loss of autonomy associated with unrecognized late-stage complications, ensuring that the final decades are marked by preserved dignity, not relentless decline. The greatest challenge posed by diabetes in the geriatric demographic is the absence of classical warning signals. Peripheral neuropathy, often causing agonizing pain in younger adults, frequently presents as simple numbness or balance issues in a patient over 70, easily dismissed as standard aging or arthritis. Far more dangerous is the creeping prevalence of cardiac autonomic dysfunction, which dampens the body's pain receptors. This means the hallmark chest pressure that warns a 60-year-old non-diabetic of an impending myocardial infarction is often muted, silent, or completely absent in the long-term diabetic. Instead of crushing chest pain, the patient might report a sudden onset of fatigue, unexplained shortness of breath during routine activity, or merely a transient drop in blood pressure upon standing, subtle whispers preceding catastrophic heart failure. In this discussion, we must confront the reality that the brain itself is a primary target. Mild to moderate cognitive dysfunction is disturbingly common in older adults with long-standing diabetes, manifesting long before traditional vascular dementia. These subtle memory issues, forgetting appointments, mismanaging medication, or displaying a general slowing of thought processes, are often misinterpreted by families and clinicians alike as the normal ebb and flow of sin. It is a slow, quiet sabotage that undermines adherence to the very regimen designed to keep them healthy. We spend countless hours worrying about perfect HbA1c control, yet overlook the fact that the patient is now cognitively incapable of remembering whether they took their morning insulin or their evening We have reached a point in modern medicine where we successfully prevent macrovascular amputations only to watch the patient gradually lose the capacity to manage their own bank account. A truly grim trade-off in the pursuit of longevity. This dangerous lack of symptoms, the silent ischemia, and the masked neuropathy, demands a fundamental recalibration of what constitutes risk. A patient reporting no chest pain is not necessarily a patient free of coronary artery disease. Cardiac autonomic neuropathy profoundly impacts exercise tolerance and heart rate variability, removing the essential physiological signals needed to detect silent coronary blockages. Clinicians must actively screen for these unseen threats, moving beyond simple metrics. The geriatric diabetic is less likely to collapse dramatically with an acute heart attack and far more likely to experience a precipitous decline in functional status or a non-specific acute illness that is secretly driven by cardiac injury. They are, in essence, walking time bombs whose detonators, the pain and warning systems, have been conveniently disabled by decades of high glucose exposure. Future clinical strategies for older adults with diabetes must urgently pivot toward advanced, non-invasive screening methods for cognitive function and cardiac autonomic integrity. We cannot wait for overt symptoms, a stroke, a severe fall resulting from unrecognized orthostatic hypotension, or a hospitalization for severe hypoglycemia before intervening. The goal is to institute screening protocols, such as assessing orthostatic vitals and utilizing short-validated cognitive scales as routine components of the annual physical. Only through this focused, proactive surveillance can we hope to disrupt the trajectory of relentless decline, ensuring that the years gained by advanced diabetes treatments are years of quality, self-directed life, rather than mere clinical survival.